Hello, my name is Dr. Irina Murakhovskaya, hematologist in Montefiore Medical Center, Albert Einstein College of Medicine. And today I'll be speaking to you about cold agglutinin disease, pharmacological treatment, and clinical monitoring. But first, let's discuss what's cold agglutinin disease, what's autoimmune hemolytic anemia. So cold agglutinin disease is a rare type of autoimmune hemolytic anemia, which is a group of disorders which is characterized by antibody-mediated red cell destruction. The antibodies can be warm reactive at a temperature of 37 degrees centigrade, which is close to the core body temperature, which is the core body temperature, or cold reactive with a temperature optimal below the core body temperature. And accordingly, the autoimmune hemolytic anemia can be characterized as warm or cold autoimmune hemolytic anemia based on the thermal amplitude of the pathogenic antibodies. Cold autoimmune hemolytic anemia is caused by cold agglutinins, which are the antibodies that agglutinate red blood cell at the optimum temperature of -4 degrees centigrade. And in most cases, those are IgM antibodies, although rarely they can be IgG or IgA. And they have a specificity against carbohydrate antigens on the red cell surface, which are the I-class antigens. Here on the bottom left, you can see a smear of a patient with a cold agglutinin disease, with agglutination present on the cells. And on the right is a schematic of the mechanism of the hemolysis caused by cold agglutinin. So IgM, which is a pentameric antibody, has ability to bind complement and fix complement component C1, which initiates activation of the classical complement pathway with subsequent deposition of C2, C4, and eventually C3. The red cells that are absonized by C3 are phagocytized in the liver, and in the conditions of excessive complement activation, such as during pregnancy, surgery, and intravascular hemolysis can happen by completion of the membrane attack complex and direct lysis in the circulation. But this is a much less common complication. The predominant mechanism of hemolysis in patients with cold agglutinin disease is extravascular. So primary cold agglutinin disease refers to a clonal B-cell lymphoproliferative disorder of the bone marrow, which is now recognized in the WHO revision of the clonal hematolymphoid neoplasms published in 2022. The cells are typically small mature lymphocytes, which are CD20 positive, surface IgM positive. About 50% of cases have CD5 from their surface, and they're distributed in the nodular discrete infiltrates, which represent less than 10% of bone marrow cellularity. This immunophenotype is similar to marginal zone as well as lymphoplasmacytic lymphoma, but in contrast from lymphoplasmacytic lymphoma, the MYD88L265P mutation testing is typically negative. And in a contrast to marginal zone lymphoma, there is no overt evidence of lymphoma otherwise. These cells also have somatically mutated monoclonal IGHV gene rearrangement. In contrast, the cold agglutinin syndrome is typically a secondary disease, which can be seen in a setting of infection, such as mycoplasma or Epstein-Barr virus, autoimmune disorders, or an aggressive type of lymphoma. Here on the right, you can see a low power view of a bone marrow biopsy with a small lymphoid aggregate in a patient with cold agglutinin disease. And on a close-up, you can see that there are small mature B cells, homogeneous, no atypical features, and no excess of lymphoplasmacytoid lymphocytes. So cold agglutinin disease represents 15 to 30% of autoimmune hemolytic anemias and is characterized by a monospecific direct antiglobulin test, which is strongly positive for C3d, and it's usually negative, but can be also weakly positive for IgG, and a cold agglutinin titer of greater than 64 at 4 degrees centigrade, although some patients can have a lower cold agglutinin titer. In about 90% of cases, B-cell lymphoproliferative disorder is detectable in the blood or a bone marrow without overt evidence of malignancy clinically or radiographically. The prevalence of cold agglutinin disease is 5 to 20 cases per million, and the incidence is 0.5 to 1.9 cases per million per year, with this 4 times variation between cold and warm climates. between Norway and Lombardy, Italy. The median age of onset of cold agglutinin disease is 67 years old with slight female predominance, but frequently the diagnosis is delayed in many patients. The signs and symptoms of cold agglutinin disease include hemolytic anemia, with fatigue frequently out of proportion of the anemia, hepatosplenomegaly, iron overload, thromboembolism can be seen in about 13 to 30% of patients. And a significant proportion of patients also suffers from cold-induced vasculatory symptoms, including Raynaud's syndrome, which is here on the bottom left, livedo reticularis, or acrocyanosis on the bottom right. In the largest cohort study in Europe, which included 232 patients, the median baseline hemoglobin was 9.3, with about a quarter of the patients having severe anemia and hemoglobin less than 8, about a third having moderate anemia with hemoglobin less than 10, and 40% of patients had hemoglobin above 10. Cold-induced circulatory symptoms were present in about half the patients, and about a quarter never required therapy. And of those who were treated, the median number of therapy required was 2. Diagnostic evaluation of cold agglutinin disease includes complete blood count, metabolic panel with bilirubin, which is typically elevated in patients with cold agglutinin disease, reticulocyte count, and haptoglobin. It should be noted that patients may have inappropriately low reticulocyte count at presentation, so not a lack of elevation of reticulocyte count should not preclude the diagnosis of cold agglutinin disease in an appropriate scenario. Direct Coombs is positive for C3d only, but can be positive for IgG weakly in about 20% of cases. I mentioned cold agglutinin. Thermal amplitude is not required for diagnosis, but may be helpful for clinical evaluation. About 90% of patients with cold agglutinin disease have presence of monoclonal protein on the serum protein electrophoresis. In most cases, it's an IgM-kappa monoclonal protein. Bone marrow biopsy should be performed to rule out an overt lymphoma and to confirm histology. And as we've discussed, typically we see a clonal population of CD20 positive, kappa positive lymphocytes with no evidence of MYD88 mutation. And patients should be evaluated for occult malignancy and infection as appropriate. Not everybody requires therapy for a cold agglutinin disease, with a quarter of patients never needing therapy. The indications to treat would be severe cold-induced vascular symptoms or symptomatic anemia, with most patients with hemoglobin less than 10 having severe fatigue and requiring therapy. So what are the therapeutic options for cold agglutinin disease? The treatment options include targeting the clone producing pathogenic antibodies, which are typically B cells and possibly plasma cell-directed therapies, and these include rituximab with or without bendamustine, rituximab fludarabine or bortezomib, complement inhibition with sutimlimab, or addressing bone marrow hyperproliferation, which can be seen in a significant amount of people with recombinant erythropoietin. And we'll go through these treatment options one by one. How do we choose an appropriate therapy for a patient with cold agglutinin disease? There's a number of considerations. In general, the B-cell directed therapies have an advantage of having defined duration of treatment. They're effective for cold-induced vascular symptoms as well as the anemia. The negatives are delayed responses in a number of patients, risk of secondary malignancies, particularly with fludarabine-based therapies, concern for infectious complications, and limited response duration, particularly in patients treated with single-agent rituximab. Complement inhibition, the advantages is a rapid onset of action, and the complement inhibition can be used and is highly effective in an acute setting and has even replaced plasmapheresis as initial therapy in some of these patients. This is a highly effective therapy with high response rate and effective control of the anemia, and as well as good side effect profile and is generally well tolerated. The negatives are the need for an ongoing therapy, and complement inhibition prevents hemolysis but has no effect on cold-induced vascular symptoms. So now we'll go through some data for each of these options. So rituximab monotherapy has been prospectively studied in a few trials, as well as retrospectively. Typical dose used is 375 milligrams per meter squared, administered once weekly for 4 total doses. A lower dose of rituximab has been attempted, however, did not produce favorable results. Typically, response rate is 45 to 59%. Most of the responses are partial, and the median time to response is 1.5 to 3 months, with duration of response of 6.5 to 11 months. Patients can be retreated with rituximab, and retreatment is effective in approximately 40% of patients who've previously been treated and responded to rituximab therapy in the largest series of patients who were treated with rituximab. So Norwegian prospective single-arm trial in 2010 attempted to improve upon the responses we see with rituximab. 29 patients prospectively were studied and received rituximab 375 milligrams per meter squared day 1 with oral fludarabine 40 milligrams per meter squared day 1 through day 5 on every 28-day cycles for a total of 4 cycles. The response rate was significantly improved at 62%, with 40% being complete responses and median response duration of 77 months, with estimated 5 years sustained remission rate of 71%. However, there was a significant number of late occurring secondary malignancies, both hematologic, including diffuse large B-cell lymphoma, acute lymphoid and myeloid leukemia, as well as myelodysplastic syndrome, as well as solid tumors, making fludarabine a less desirable choice for therapy. So rituximab bendamustine was evaluated in a prospective Nordic trial in 2017, which included 45 patients treated with rituximab 375 milligrams per meter squared on day 1, and bendamustine 90 milligrams per meter squared day 1 and day 2 in 28-day cycles for a total of 4 cycles. The response rate was 78% with 53% complete responses, and the median estimated response duration was not reached after 88 months of follow-up, with estimated 5-year sustained remission rate of 77%. On the left, you can see the probability of sustained remission as a function of time, and you can see that potentially there is a group of people who go into sustained remission without evidence of relapse after 5 years of therapy. The time to response with rituximab bendamustine can be delayed by 1 to 3 months, and responses do get better over time on subsequent studies, suggesting potential effect of long-lived plasma cells on the improvement in response. In patients who progress on bendamustine rituximab B-cell-directed therapy, consideration can be given to treatment with bortezomib, which was evaluated in one prospective trial, which included 21 patients with who were either transfusion dependent or had hemoglobin of less than 10. 2 patients were excluded prior to initiation of treatment, and out of the 19 patients who've received bortezomib therapy, which included a single course of bortezomib, 1.3 milligrams per meter squared, which was administered intravenously on day 1, 4, 8, and 11. 15.8% of patients achieved complete response with this therapy, and 15.8% of patients achieved partial response with this therapy. So the overall response rate was 32%, which is fairly impressive considering this was a group of refractory patients and they received only 1 course of therapy. In patients who progress on B-cell directed therapy, bortezomib can be a consideration, particularly if significant cold-induced vasculatory symptoms are prominent. Recombinant erythropoietin is a treatment that attempts to address the inadequate erythropoietic response that we can see in up to 30% of patients, and this can be due either to lower levels of our reticulocytes as well as the endogenous erythropoietin levels. And inadequate reticulocytosis has been associated with a significantly more severe anemia, increased need for transfusions, as well as hospitalizations. So use of recombinant erythropoietin therapy has been evaluated in a prospective single-center Italian cohort study of 47 patients with autoimmune hemolytic anemia, 40% of whom had cold agglutinin disease. The patients also had inadequate reticulocytosis and endogenous erythropoietin levels. Erythropoietin alpha was administered at a dose of 40,000 units per week subcutaneously until hemoglobin was greater than 11. The overall response rate was 55% at 15 days, 74% in 1 month, and improved over time, as you can see in the graph on the top left. And the hemoglobin median increase was 1.4 grams per deciliter and 2.4 grams per deciliter at 15 and 30 days, respectively, and again, improved over time. This correlated with reduction in need for transfusion from 30% to less than 10% after 15 days. So recombinant erythropoietin therapy can be considered as an adjunct to immunosuppressive therapy in patients with suboptimal erythropoietic response. Now we'll move to the complement inhibitors. So sutimlimab is a C1s inhibitor and is the first therapy for cold agglutinin disease that was approved in February of 2022. The approval was based on 2 prospective clinical trials. The Cardinal trial was an open-label, single-arm trial, which included 20 patients with cold agglutinin disease who received a blood transfusion within the previous 6 months. In patients who received sutimlimab, 54% met the composite primary endpoint of hemoglobin greater than 12 grams per deciliter or greater than 2 grams per deciliter increase from baseline. And 71% of patients achieved transfusion independence after week 5. These findings were accompanied by clinically significant improvement in FACIT-Fatigue score after week 1. The CADENZA study was a double-blind, prospective, placebo-controlled, randomized controlled clinical trial, which included patients with hemoglobin less than 10 and symptoms of anemia with no evidence of transfusion within the past 6 months. The primary endpoint of the study was a hemoglobin increase of greater than 1.5 grams per deciliter in the absence of transfusion and forbidden medications. And this was met by 73% of patients who received sutimlimab and 15% of patients who received placebo. This was highly statistically significant. This was accompanied by improvement in hemoglobin, hemolytic markers, and FACIT-Fatigue score. And here on the left, you can see the initial 26-week period of randomization, and pretty much at a week after initiation of therapy, you can see the separation of curve for median hemoglobin levels, significantly favoring sutimlimab, and the separation peaked at about 7 to 9 weeks and remained stable for the duration of the study. So this table summarized other treatment options that have been tried in patients with cold agglutinin disease, and I just wanted to point out a couple of things. We all know that cold agglutinin disease should not be treated with corticosteroids, and in this data is from the largest cohort study of 232 patients, in which 73 actually were treated with corticosteroids. You can see here the overall response rate with corticosteroid therapy was only 16%, with no complete responses. The corticosteroids are very difficult to taper in this patient population, and they should not be used. Similarly, cyclophosphamide therapy was associated with a 25% response rate with no complete responses. Splenectomy has not been effective as well. We've discussed the rituximab and the bortezomib data. Monitoring of patients with cold agglutinin disease and therapy include CBC, complete blood count and hemoglobin levels, determination of markers of hemolysis, including bilirubin, haptoglobin, lactate dehydrogenase, and reticulocyte count, serum protein electrophoresis, monitoring the monoclonal spike levels, as well as IgM levels. These patients are prone to iron overload, so I would suggest monitoring ferritin and iron studies at least annually. Since responses to B-cell directed therapy can be delayed, If the B-cell directed therapy is chosen as a treatment option, I would not alter therapy for the first 2 to 3 months. That would include adding additional therapy or extending the course of therapy beyond 4 cycles with rituximab bendamustine, for example. There is a number of new investigational agents that are being tried and evaluated in cold agglutinin disease. They include BTK inhibitors. The ibrutinib has shown responses both in terms of anemia as well as circulatory symptoms in retrospective studies. And currently there is a trial in Europe that will be evaluating zanubrutinib in cold agglutinin disease. CD38 antibodies such as daratumumab have also been reported to have efficacy, but predominantly in case reports. Pegcetacoplan, which is a C3 inhibitor, both C3 convertase as well as C3b inhibitor, has demonstrated efficacy in cold agglutinin disease in a phase 2 trial. In the abstract, this study has not been published yet. BIVV020 is a C1s inhibitor that's building up on the sutimlimab's efficacy, targeting the C1s mediated complement mediated red cell destruction. In contrast to sutimlimab, it's only needs to be administered every 2 months as opposed to every 2 weeks. Iptacopan is an oral factor B inhibitor, which is an inhibitor of alternative complement pathway, and is currently being evaluated in a basket trial in a number of autoimmune hematologic conditions, including cold agglutinin disease. And a new class of agent is povetacicept, which is a BAFF and APRIL inhibitor. Inhibition of both BAFF, which is responsible for B-cell survival and maturation and differentiation, as well as APRIL, which leads to suppression of B cells, suppression of immunoglobulin production, as well as plasma cell depletion. And this agent is also being studied in a basket study for autoimmune hematologic conditions, including cold agglutinin disease. I would like to thank you for listening.